Good afternoon. Welcome to UCSF Department of Medicine Grand Rounds. I'm Bob Wachter, chair of the department. Very exciting, excited about today's session. Actually, we're doing a similar thing next week where we have one of our colleagues in internal medicine pairing with one of our colleagues in surgery to talk about an issue where our collaboration is absolutely crucial. Today, we're going to talk about the management of obesity. Obviously, as everybody knows, the national and worldwide epidemic of obesity leads to tremendous amounts of morbidity and mortality. Up until very recently, we had options of diet and exercise. That's been our typical response. And obviously, the results of that are often unsatisfying. And when periodically we would turn to our surgical colleagues for a surgical procedure, and obviously that's a pretty big deal. And so when scientists discovered that GLP-1 agonists like semaglutide, which sells under the brands of Ozempic or Wegovy, led to substantial weight loss, the landscape of obesity management changed dramatically, creating some new options that we really didn't have before. And yet surgical approaches remain appropriate for certain patients. And so the bottom line is this is one of the more important areas that we face in both medicine and surgery, and an area that's rapidly changing with some new options that we didn't have as recently as a few years ago. And so it seemed like a great idea to bring together two of our colleagues to teach us about multimodal treatment of obesity in 2023, and the role of lifestyle interventions, anti-obesity medications, as well as bariatric surgery. Our speakers today are Diana Thiara, who's assistant professor in our Department of Medicine and is the medical director of the Medical Weight Management Clinic in the Division of General Internal Medicine at UCSF Health. And Diana's work focuses on innovative patient programs for weight management and wellness. And I assume these days a fair amount of it relates to whether patients should be on one of these medicines and how well they work. So Diana will speak first, and after her will be our friend Jonathan Carter, who is professor of surgery and program director of the Advanced GI Minimally Invasive Bariatric Surgery Fellowship in the Division of General Surgery at UCSF Health. And Jonathan is an expert in bariatric surgery and minimally advanced approaches such as laparoscopic and robotic surgery for a variety of disorders. So John, welcome. Good to see you. And I think we're going to start off with Diana. The format here will be each one giving a short 20-ish minute lecture, and then we'll have 10 or 15 minutes of discussion at the end. So let me hand it off to Diana to begin.
All right. Let me just get my slides up. Okay, well, thank you, Dr. Wachter. Dr. Carter and I are both honored to be here today to talk to you all about obesity management in 2023. So in terms of our objectives, we hope that by the end of today, you all understand current treatments for obesity and the relative impact of each on the disease, and that you're familiar with BMI-based guidelines for the treatment of obesity. In terms of our outline, we'll first briefly talk about how we diagnose obesity, and then we'll spend the bulk of today discussing treatment options. I'll go through lifestyle change and medications, and then pass the mic to Dr. Carter to discuss surgical options. So how do we diagnose obesity? Everyone here is very familiar with BMI. That's what we use to diagnose our patients with overweight or obesity. BMI is a super simple calculation that takes into account someone's weight in kilograms and their height in meters squared. From that, we get a number, and we classify patients as having normal, overweight, or obese BMIs. We further categorize obesity as class 1, class 2, or class 3 based on increasing severity of disease. We know that at population levels, BMI has high sensitivity at predicting cardiometabolic disease, and that's why we use it as a screening tool. But we also know that BMI is ripe with controversy. Since it's used so widely, I think it's really important for us all to understand the limitations of BMI so that we can better care for our patients. First, let's talk about how BMI was developed. BMI was initially developed in the 1800s by a Belgian scientist who was trying to identify the ideal weight for the average white man. It was adopted to its modern form in 1972 by Ansel Keys. He determined, based on population-level data, that BMI was an appropriate surrogate for body fat, which correlates to cardiometabolic health. But again, this was only in white men. This exclusionary history clearly exemplifies where our present-day limitations lie. First and foremost, these limitations are around race. We know that racial groups experience different rates of cardiometabolic disease and mortality at different BMIs. The first example is in our non-Latinx Black American patients. This population has greater muscle to fat ratio than white populations. Therefore, BMI can overpredict cardiometabolic risk. On the other end of the spectrum are our Asian and Asian American patients. In this population, BMI underpredicts cardiometabolic risk. A lot of work has been done in this space, and we have lower BMI cutoffs to diagnose overweight and obesity. So for our Asian and Asian American patients, a BMI of greater than or equal to 24 is considered overweight, and a BMI of greater than or equal to 27 is considered obese. The next main limitation is in sex. We know that women have different body composition than men with higher rates of adiposity. But we also know that premenopausal women have cardiometabolic hormones that are protective. So a lot of work still needs to be done in this space to help create BMI cutoffs for both premenopausal and postmenopausal women that better predict cardiometabolic risk for these patients. It's well established that extremes of muscle mass can also be limiting use of BMI. For athletes with a lot of muscle, BMI is falsely elevated. And for our sarcopenic or older patients who have lower muscle mass, we know that BMI is falsely lowered. So what should we take away? Well, ultimately, we should be using BMI as a screening tool, but there are undoubtedly better methods. We know that body composition scans would definitely be superior, but these tests are incredibly costly, both financially and from a time standpoint. It's just not a realistic screening tool. Ultimately, you should screen your patients for elevated BMI, but then you should look at your patients as individuals, understand their cardiometabolic disease risk, their comorbidities, and current nutrition and activity habits as you provide that individual guidance on weight. So now that we've discussed diagnosis, let's get into treatment. We think about treating obesity as a pyramid. As BMI increases, intensity of treatment can also increase. At the base of the pyramid here, we see primary care providers. PCPs should feel comfortable and confident in discussing weight and lifestyle change with their patients. When patients have BMIs in the obese category or are overweight with comorbidities, primary care providers can consider stepping up treatment approaches within their own clinical practice through lifestyle change work and medications. PCPs can also refer to specialty weight management programs like ours at UCSF. Through referrals to specialty weight management programs, patients receive regular lifestyle change counseling from doctors, dietitians, and behavioralists, and patients can benefit from more intensive treatment options like medications or meal replacement. Above a BMI of 30, depending on clinical context, patients can also be referred to bariatric surgery teams. But remember, while we have this treatment pyramid in mind as we care for our patients, it's ultimately up to our patients to decide what treatment options are best for them. As we get into treatment, we should take a step back and understand what is our goal for treating obesity. The answer is we want to help our patients improve their health. And it's been very well studied that even with modest weight loss, we can see improvements in patients' health. What you can see here is that even at the 5 to 10% body weight loss category, we see improvements in both cardiometabolic and mechanical diseases that are associated with obesity. At higher rates of weight loss, we see even greater improvement. So what does that mean? It means don't fixate on BMI targets. Don't fixate on this goal that patients need to have normal or overweight BMI targets to be healthy. This number can be very daunting for patients, and we need to reassure our patients that even with modest % weight loss, they can see improvements in their overall health. The other thing that's really important is that we as medical providers need to shift our view on obesity. It's a chronic metabolic disease that requires chronic disease management. We should not expect short-term interventions to have long-term results. And just like any other chronic disease state, we should expect times when obesity will be less well controlled, and that is okay. So let's get into it. Lifestyle change is really the crux of all of our work in obesity management. Whether we go on to do more intensive measures like medications or surgery, we really want to make sure we're providing our patients with a solid foundation of diet and exercise counseling. The main aspect of lifestyle change is diet, and the main question I hear from patients, friends, family, peers is what diets work for weight loss? And the answer is quite simple. The diet your patient can adhere to for the long term is the best diet for your patient. We know that macronutrient composition does not predict weight loss. This has been shown over and over again for the past few decades through large-scale RCTs as well as meta-analyses. Weight cycling is harmful for net body weight throughout someone's life, so we really want to focus on sustainable lifestyle changes for our patients. So how do we help patients think about diet? The main goal is around calorie reduction. We want our patients to be on a 500 calorie day deficit compared to their baseline caloric intake. Self-monitoring is key to helping patients achieve that calorie reduction. Patients can use whatever they're able to use. It can be something like apps, journals, Excel spreadsheets, pictures. Whatever it is that they can adhere to and keep up with the longest is the best intervention for them. And another really important thing for us to focus on is anti-oppressive and culturally specific guidance when we talk about diet. And more to come on that in a minute. So how do we actually help our patients reach this goal of sustainable calorie reduction? Well, I think this quote by Michael Pollan encapsulates the message quite well. Eat food, not too much, and mostly plants. So what does this mean? So we need to encourage our patients to have healthy relationships with food. Eating is a good thing. We have to eat. Food is good for us. We don't want to promote restrictive eating. Restrictive eating is unhealthy, and it can oftentimes cycle with binge eating. The other thing is that patients need to focus on portion control. This can inherently help with calorie reduction. And the last bit is that we should help our patients prioritize fresh and minimally processed foods when they're thinking about their nutrition. When we talk about dietary counseling and portion control, we're all familiar with something like the plate method. However, the plate method is not an inclusive or anti-oppressive approach to nutrition counseling. It is a white, Western-centric view on the ideal way to eat. And by using that model, we are inherently telling our patients from minority groups that their way of eating is bad. Furthermore, the nutrition guidance from something like the plate method is not really applicable to these patients' lives, values, or heritage. One alternative model for an anti-oppressive dietary counseling approach is the old ways heritage pyramids and plates of expression. These pyramids and plates incorporate healthy food traditions of different cultures. This is new knowledge for all of us who aren't a part of these heritages, but I really encourage all of you to learn more about the different food traditions of the patients we serve in order to help our patients make dietary changes that are important for their health. So the next big part of lifestyle change is exercise. According to the American College of Sports Medicine and CDC, adults should be engaging in 150 minutes of moderate intensity aerobic each week, plus strength training twice a week. These guidelines are meant for adults to maintain their weight. When it comes to exercise and weight loss, we know that in most cases, exercise alone does not contribute to weight loss in a meaningful way. This table here summarizes years of diet, exercise, and weight loss studies. And what it shows is that with aerobic exercise alone, patients only lose 0 to 3% of their body weight. This is not a clinically meaningful percentage. When we look at resistance training or the combination of aerobic and resistance training, we see much of the same. Now, the caveat is in people who engage in high levels of exercise. So for those who are exercising 45 minutes to an hour, 5 days a week, and burning 500 to 700 calories a session, we can start to see clinically meaningful weight loss. But this is a huge time commitment. One of the biggest barriers our patients face is having not enough time to focus on their lifestyle. Another huge barrier is decreased exercise tolerance due to MSK issues or poor cardiopulmonary fitness. So for most of our patients, this is just not a realistic solution for initial weight loss. But remember, what I'm talking about is initial weight loss. Exercise is super important for maintenance of weight loss and for other aspects of health. So it is important for us to help our patients with their exercise. It's just not adequate on its own for initial weight loss in patients with elevated BMI. Now that we've gone through lifestyle change, let's talk about anti-obesity medications. Medications for weight loss are FDA approved for people with a BMI greater than or equal to 27 with comorbidities or a BMI of greater than or equal to 30. There are currently 5 medications that are FDA approved for long-term use in obesity: orlistat, Contrave, Saxenda, Qsymia, and Wegovy. Today, we're going to focus on GLP-1 receptor agonists, so that will be Saxenda and Wegovy only. Before we talk about medications, it's super important to understand the physiology of obesity. When we think about how we as humans evolved, our primitive desire and need to eat was controlled by energy homeostasis, which is regulated by complex peripheral and central feedback loops that center on the hypothalamus. Historically, most medications for weight loss have centered on promoting the anorexigenic pathway and inhibiting the orexigenic pathway. Simply put, they function to suppress appetite centrally. The GLP-1 receptor agonists have made a huge splash because they also have peripheral mechanisms of action. There are currently 2 FDA-approved GLP-1 receptor agonists for weight loss, and they are liraglutide, or the brand name Saxenda, and semaglutide, with the brand name of Wegovy. And so these medications work in 4 ways. They act centrally to promote satiety via POMC-CART in the hypothalamus, and then they act peripherally at the gastric fundus to decrease gastric emptying. They act via the pancreas to increase insulin secretion, and they act via the liver to improve insulin sensitivity. When we look at studies done for medications for weight loss, it's really important to look at the study design to understand what intervention patients received in addition to medication or placebo. So the STEP 1 trial looked at use of Wegovy in individuals with obesity. It enrolled 2,000 participants. The participants were randomized either to semaglutide 2.4 milligrams a week versus placebo, and the intervention was for 68 weeks. Additionally, all participants received lifestyle interventions. They had counseling sessions monthly to help focus on reduced calorie diets and physical activity. They were also instructed to perform daily self-monitoring with things like apps or study diaries. This self-monitoring info was then reviewed at regular counseling sessions to help patients better optimize their calorie-reduced diets and physical activity. This bit is key. These people were not just meeting with their providers once every few months, receiving medications through online portals like MyChart. These patients were engaged in intensive lifestyle change work throughout the entire time they were receiving the medication. I point this out because we need to be mirroring this intervention with our patients on medications for weight loss if we expect to have the same level of results. That being said, the results from STEP 1 were amazing. So in participants who were receiving Wegovy, they had a 14.9% body weight reduction at 68 weeks. When we subtract out the placebo effect, that's about 12.5% body weight loss. Even more important is looking at STEP 5, which was the maintenance of weight loss study. So at the 2-year mark, the individuals who were receiving semaglutide had 5.2 body weight reduction, which was a 12.6 weight loss when we subtract out the placebo effect. The other important thing to look at is what happens after stopping this medication. So the step 1 extension results tell us a lot. What we see here is that after patients stopped the medication, 1 year after that discontinuation, they regained 2/3 of their body weight back. This shows us that, just like we discussed before, obesity is a chronic disease that requires long-term treatment. Medications for weight loss are meant for long-term use. When it comes to the practical things to know about GLP-1 receptor agonists, you should know about the side effects. We're very familiar with things like nausea, vomiting, other GI side effects. We hear a lot about the rare but serious pancreatitis and cholecystitis. I bolded suicidal ideation because this is another rare but serious side effect that's oftentimes not discussed. In terms of contraindications, again, a lot of us have heard about the black box warning associated with medullary thyroid cancer, but pregnancy is also a contraindication. Wegovy and other GLP-1 receptor agonists can increase fetal loss, so women who are pregnant cannot be on GLP-1 receptor agonists, and they should not be on this medication 2 months prior to conception. In terms of dosing, liraglutide is a daily injection, whereas semaglutide is weekly. Some key facts are that Wegovy and Ozempic, while they both are semaglutide, they are technically not the same medication. The FDA has only approved Wegovy for obesity, and they've only approved Ozempic for diabetes. If you are prescribing them for other indications, insurance companies will not cover it, and it will drive your staff crazy. When we compare Wegovy and Saxenda, the step 8 results showed that Wegovy is definitely the superior medication. Wegovy has higher weight loss, fewer side effects, and is easier to use. In terms of cost, more and more insurance companies are covering the use of Wegovy for obesity. However, Medicare still does not cover medications for weight loss, and if a patient is paying out of pocket, Wegovy is $1,400 a month. I want to briefly discuss another medication called tirzepatide. This is a novel dual GIP and GLP-1 receptor agonist that has been FDA approved for diabetes, but has not yet been FDA approved for weight loss. In addition to the GLP-1 effects we discussed, tirzepatide has added GIP benefits, which are increased lipolysis and fatty acid synthesis. The SURMOUNT-1 results were published about a year ago in the New England Journal of Medicine, and the results have been astounding. So in the group that received the highest dose of tirzepatide, we see about 18% body weight loss when compared to placebo. And what's even more amazing is the number of participants that reach high body weight loss percentage. Over half the group had over 20% body weight loss. When we compare that to the step 1 results for semaglutide, there were only about 1/3 of participants who reached that metric. Additionally, for tirzepatide, 36% of participants achieved greater than 25% body weight loss. That level of weight loss has never been reached consistently with any medical weight management intervention before. So when tirzepatide is FDA approved for obesity, this is going to be a really impactful medication for our patients. Again, when we look at the study design, it's really important to note that investigators chose patients who they deemed to be well motivated to engage in lifestyle change. And just like in the step 1 trials, patients received intensive lifestyle counseling with diet and exercise for the whole study duration. And what's on the horizon? So right now, there are 2 oral GLP-1 receptor agonists that are being studied for weight loss. One is danuglipron, which is totally new to the market. The studies for diabetes are just coming out, so that one will probably take longer. Higher dose Rybelsus is also now being studied. Novo Nordisk just put out a statement this week about this medication. Further on the horizon are new triple receptor agonists. These are GIP, GLP, and glucagon receptor agonists. They just completed their phase 2 in October. We're still waiting to see the results, so it will be several years before we see how this can be helpful for our patients with obesity, but I would definitely keep an eye on these new triple receptor agonists. So now that we've gone through meds, we will pivot to Dr. Carter, who will walk us through surgery.
Okay, thank you, Dr. Thiara. Super exciting. So I just want to make sure everyone caught that. We now have effective medication for obesity for the first time, really. It's a lot of people have been lauding this as a revolution, and all of us who treat obesity for a living are super, super excited. One thing to know about tirzepatide in the SURMOUNT-1, if you look at dropout rates, there was a higher dropout rate in the placebo arm than in the study drug arm, which is very unusual in clinical trials. And that just tells you, that's a clue that you've got a really good drug on your hands whenever you see that. So let's talk about surgery a little bit. So we use surgery for the most extreme form of the disease, and that's people at the highest ends of the BMI spectrum. The current indications for bariatric surgery are patients who have a BMI of 35 or higher, or if they already have metabolic disease like diabetes, hypertension, hypercholesterolemia, sleep apnea, DJD, then we relax the cutoff down to 30. Now, these are relatively new guidelines. They're less stringent than the guidelines even 2 years ago. And the reason is based upon the recognition that bariatric surgery is highly effective and highly durable in patients with these lower-ish BMI categories. So I'm going to talk a little bit about gastric bypass. Gastric bypass has been around for 50 years. It's very well studied, very well tailored and refined. And what we do in a gastric bypass is we take a stapler and we divide the stomach into two unequal halves. The upper part, called the gastric pouch, is about the size of a golf ball or an egg. The lower part, the gastric remnant, remains. And when we do a gastric bypass, we don't take any tissue out. We're just rearranging the plumbing, so to speak. Now, if we stop there, what would happen? Food would come down the esophagus and enter the pouch, and it would have nowhere to go. So what we do is we divide the jejunum, and we bring up one side of it, called a roux limb, and we create an anastomosis to the gastric pouch. That allows a pathway for food to egress out of the esophagus and the pouch. Now, you still have a stomach. Stomach still makes acid and gastric juice, and those juices go through the pylorus and meet up with bile from the liver and pancreatic juice from the pancreas. And all those digestive juices come down and would have nowhere to go, except the surgeon makes another connection between the side of the roux limb and this proximal jejunum, which is called the pancreaticobiliary limb. And that allows the food stream and the digestive juices to come together and digestion to proceed normally throughout the common channel of the intestines. Now I'm going to show you a video here of us actually doing the operation. This operation is done with a minimally invasive laparoscopic technique. Nowadays, more and more surgeons are doing it with a minimally invasive robotic technique. If any of you are squeamish or have sensitive stomachs, close your eyes because we're going to be operating on the intestines, and I'll let you know when it's all done. You can open your eyes again. So the surgery starts out, we divide the great omentum. This is the transverse colon just below there, and make a slit that will accommodate the future roux limb. We then flip the transverse colon up towards the head, and we identify the ligament of Treitz. That's the very first portion of the jejunum. Then we walk down the jejunum about 50 centimeters. There's some data that the operation works even better for diabetics if you have a slightly longer pancreaticobiliary limb. So in Europe, some surgeons will use a pancreaticobiliary limb up to 200 centimeters. We then use this little nifty surgical stapler. What this does is it fires 3 rows of staples on each side, and then divides down the middle to divide the intestines. And so one end will be our pancreaticobiliary limb, the other will be our roux limb. So on the left side of the screen, that's the roux limb, and we measure out a 100 centimeter roux limb, leaving plus maybe 10 extra centimeters to trim off at the end. And our first task is we're going to do that downstream anastomosis. That's called the jejunal-jejunostomy. And that's the connection between the pancreaticobiliary limb and the common channel here. And so the way we do that technically is we put a stay suture tying intracorporally, and then we cut 2 little holes in the small intestines. And we do that with a cutting and sealing device. And then we go back and use our linear stapler. This is 60 millimeters long, and fire that. And that creates a side-to-side but functional end-to-side anastomosis. We take a look inside there to make sure there's no bleeding. If there's a little pumper, we'll zap it. You can see what the mucosa looks like inside there. And to complete this anastomosis, we just need to close that common enterotomy. So we place a couple stay sutures and then staple across. And that creates a perfectly watertight double stapled anastomosis. There's a few weak points, and we'll put a few stitches to reinforce in certain areas. So now we're going to go up and make our gastric pouch. You can see this patient has a very enlarged liver that is a little bit fatty. That's pretty common in this patient population. Here I'm retracting the lesser omentum, and we're looking at the lesser curve of the stomach. We're dividing some of the terminal branches of the left gastric artery and creating a window until we get to the lesser sac posteriorly, which is a free space behind there. We then use our linear stapler and use that to create our gastric pouch, and we do that with a single horizontal fire. So towards the top of the screen, that is the future gastric pouch, and then towards the bottom of the screen will be the gastric remnant. And then we do several vertical fires, aiming for the His angle. And you can see the patient's spleen just off the tip of the stapler. We got to kind of keep an eye on that, make sure we don't bang it up and make it bleed. And so there's our first fire. And here's our second fire. You can see the patient's diaphragm and beating heart beyond the tip of the stapler. And we make sure, you can see the stomach always kisses the spleen way up there at the His angle. So it's a little bit of a tricky area. And then the pouch is done. So the next step is we will make a gastrojejunostomy. So we've got to connect that roux limb to the gastric pouch. So the way we do that is with a device called an oral anvil. And we use an orogastric tube to pass a little metal plate. And this acts as the back plate for the surgical stapler. Now, a surgical stapler works the same way as a stapler that you use to staple paper in your office. There's kind of a U-shaped staple, and then it gets crimped across a back plate, a metal back plate. And so the way this works is we take the roux limb, we cut off the end of the roux limb so that there's a hole in it. And then we introduce a EEA stapler. This is a stapler that is designed to staple in a circle and then cut a hole out the middle. So the end result is kind of like a donut. And so we introduce that into the roux limb. We pass the central trocar. We mate that up with the back plate. And once we do that, we bring the tissue together and fire the stapler. And boom, now we've got a new gastrojejunostomy. It's a perfect circle. And there's a donut cut out the middle. So that's our gastrojejunostomy. The operation is completed by just stapling off the hole that we made in the roux limb. And we do that pretty close to the gastrojejunostomy so that the patient doesn't have a candy cane. So this operation takes about 2 to 3 hours to perform. The patient wakes up. They spend just one night in the hospital. While they're with us, they spend some time with our nutritionist, talking about lifestyle interventions and what to eat afterwards. We also have them see our pharmacist and tweak their meds and add some vitamins. And they typically go home the day after surgery. The first week's pretty rough. They're pretty queasy. By the end of the first week, their body has recovered. And most people are back to work by the end of the second week or third week. So that's what we do. So how well does it work? So the bariatric surgery and gastric bypass in particular has been done across the world, many different countries, many different cultures, and the results have been very, very reproducible. This was a study of a group of Americans that had gastric bypass. And if you look at their baseline weight, which is 0 here, and you plot how much weight they lost as a percent of total body weight, which is the y-axis, at 2 years, on average, they lost about 35% of their total body weight. At 6 years, the weight loss is preserved with an average of about 30% total body weight. And if you follow out 12 years, you can see the average patient maintains about 30% total body weight loss. Now, there's a fair amount of variability, and that's true for all interventions with obesity. If you look at lifestyle intervention, you look at anti-obesity medications, or obesity surgery, there's a lot of variability that we see in response to the intervention. And so the standard deviation is about 10% here. What I really liked about this paper is they actually plotted every single individual patient. And so you can see there's some patients that do amazing, lose 50, 60% of their total body weight. That's usually enough to achieve a normal body weight, normal BMI. And you can see there's a sizable number of those patients out even 12 years after surgery. But on the flip side, there are some patients that don't respond strongly. There are people who lose maybe 10 or 20% of their body weight and then experience weight regain. And if you look at 12 years, there's a minority, but there are some patients who have had a relatively minimal long-term effect or even regained back to zero. Now, I put the 5% threshold here, which is, as Dr. Thiara mentioned, that's our standard threshold. If you're going to design a study for treating obesity and you want to define success, 5% weight loss is the most common threshold. And you can see with bariatric surgery, the vast majority of patients are able to maintain more than 5%. Well, why does it work? How can that happen? I mean, it's sort of a miraculous effect. And it really has to do with hormones and GI hormones specifically. I'm going to focus on one. There's a hormone called ghrelin, and it's secreted by your stomach. It's a peptide hormone, and it has receptors in your brain and your hypothalamus specifically. And when the ghrelin is high, it's telling your brain that you're hungry. And ghrelin, if you look at you or me sitting here, it follows a very interesting secretion profile during the day. You wake up and your ghrelin is a certain level, and then it starts to peak, and that causes you to feel hungry and go seek out breakfast. By eating breakfast, you suppress your own ghrelin level. And your ghrelin be suppressed for a while, you're not hungry anymore, and then around lunch, there's another peak. You'll go get your lunch, suppress your ghrelin. There's a third peak about dinner time, which is suppressed by eating dinner. In the evening, there's actually a fourth peak. And if you happen to be up and not in your bed sleeping at midnight, you're going to feel hungry. And what are you going to do? You're going to go to the fridge. That's your ghrelin speaking to your brain. I think we've all probably done that. So that's the story with ghrelin. Now, let's say we repeat the experiment after gastric bypass. This is what you see. Complete suppression of ghrelin levels after this operation. It starts to explain why patients really just never feel that hungry after they've had this. Let's talk about a few more hormones. Dr. Thiara talked to you about GLP-1, which everyone is super excited about. When we do a bypass or when we do a sleeve, we see beneficial alterations in the hormonal secretion of various GI hormones. There's less ghrelin, I told you that story, but there's also an increase in peptide YY, GIP, GLP-1, primary bile acids, as well as alterations in the microbiome. All of these hormones have receptors in the brain, the pancreas, the peripheral adipocyte mass, the liver and skeletal muscle to produce beneficial effects in metabolism that ultimately improve hypertension, diabetes, hypercholesterolemia, and the metabolic disease that we know ultimately results in excess morbidity. And that's what's really cool about bariatric surgery. And the reason I got into this wasn't so much about the weight loss. In fact, I don't even care about the weight loss that much. What's really cool is the ability to treat metabolic disease in an effective way. I'll give you a few examples. If you look at diabetes, there was a study done out of the Cleveland Clinic called the Stampede trial that randomized patients 1-to-1-to-1 with medical management, which was basically management by the endocrinologists at the clinic versus sleeve versus bypass. And they followed A1Cs out 5 years. And you can see at the start, patients started with an A1C around 9%. At 5 years, there was improvement in all three arms. Those medically treated were able to drop their A1C about a point at 5 years, but surgery really had a profound and stronger and more dramatic effect The patients with both sleeve and bypass down to about 7%. If you look at cholesterol levels, a bypass is basically as effective as statin therapy. We see about a 20% drop in LDL cholesterol and a 40% increase in HDL cholesterol after this operation. But those are just surrogate endpoints. I mean, we care about A1C and we care about cholesterol, but why do we care about that stuff? We're trying to prevent strokes and heart attacks and cardiovascular disease in our patients in the long term. So you might ask, does bariatric surgery have any impact on those endpoints? Those are the endpoints we really care about. And indeed it does. If you look at the incidence of coronary artery disease after bypass or metabolic surgery, there's about a 40% reduction over time. That's also true for nephropathy. Strokes, there's about a 33% reduction in strokes. Heart failure, there's a strong effect. There's about a 60% reduction in heart failure. Cancer incidence, we don't really think about treating obesity to be a cancer preventative strategy, but I'll tell you, when you see an obese patient, about half of their excess mortality is due to excess cancer risk specifically. And it's interesting, when we do bariatric surgery, we actually reduce all-cause cancers by about 40% over time. And the cumulative effect of the decrease in metabolic disease and the decrease in cancer rates produces a strong survival benefit in favor of surgery. And so if you look at all-cause mortality, you're about 40% less likely to die if you have the surgery than if you continue to be obese. That's a powerful statement, but it's been validated in a lot of different studies. So I'm going to say it one more time. If you have the weight loss surgery, you are 40% less likely to die from any cause. And that reduction is primarily reduction in cancers and reduction in cardiovascular events. For the individual patient, this can be quite powerful. And this is what makes coming to work fun for me. This is a patient, Patty, who has given me permission to share her story. And when she came, she was young, she had a high BMI, she had a lot of metabolic disease burden, and we did a bypass for her. And 2 years after she sent me this photo, she had just run a half marathon and achieved a normal BMI, and all of her metabolic disease was in complete remission. Pretty cool thing to do. Now, I just want to finish up a couple minutes talking about sleeve, and there's a downside to bariatric surgery. Although the risks are quite small, there is a non-zero risk of having complications. Some of those are serious. We still see leaks, we still see bleeding occasionally. You can get a DVT or a PE. And in the long term, this anatomic configuration sets you up for two long-term problems. The first is you can get a little ulcer where we connect the roux limb to the gastric pouch, and that occurs about 1% per year. And the other thing is you can get a bowel obstruction from one of these internal hernias, and that's about 1% per year. But if you're offering this in a 30-year-old, 1% per year over the course of their future life can add up. And so surgeons have looked for other procedures that could maybe improve upon the side effect profile, and that's where sleeve comes in. A sleeve is a simple operation that involves removing about 80% of the stomach. We don't touch the small intestines. Because it's simpler, the risk of getting one of those complications is a lot less. But the weight loss is pretty close to a bypass. This was data from a prospective randomized trial of sleeve versus bypass that followed patients for 10 years. Here it's plotting again the percent total body weight loss. And you can see at 1 year, people lost about 25 to 30% of their total body weight. This was over 10 years. You could see the sleeves maintained about 20% weight loss. The bypass is 25%, very similar statistically. And so it's a smaller operation, it's a safer operation, but you get about the same weight loss. And if you actually, we published this paper a couple of years ago, and if you look at the long-term complication rates and short-term complications, it's better. Serious complications all occur less than 1% of patients. Marginal ulcers and intestinal obstruction, we don't have to really worry about. The only thing we have to worry about is GERD long-term. About a third of sleeve patients develop heartburn. Typically, we see it 2 or 3 years after their sleeve. Now, one of the things about bariatric surgery, which is true for the treatment of obesity, is it's a chronic disease that requires longitudinal care. And so how do we take care of bariatric surgical patients long-term? And we expect them to see us every year. And during that visit, what do we talk about? We talk about their lifestyle. Again, everything comes down to lifestyle intervention. The bariatric surgery is just a tool to maintain that lifestyle intervention, that low-calorie diet. All bariatric patients need to go on a bariatric multivitamin. There's actually companies that make specific formulations for bariatric patients, and so we steer them towards that. The one that we use is called Bariatric ProCare. You can mail order it from the website. This is what it looks like. There's also a risk of osteopenia and osteoporosis long-term after bariatric surgery, so we recommend calcium and D. On physical exam, there's not much. A lot of patients are interested in body contouring surgery. And then we want to screen for micronutrient deficiencies. And this is the UCSF panel that we use when we see our patients. Now, I'll tell you, if a patient's taking their vitamins, it's pretty uncommon to see micronutrient deficiency. But I think all of us have seen a lot of it in aggregate, and it's usually because the patient has stopped taking their vitamins. So I'll leave it at that, and I think we'll open it up for questions.
Fabulous. To you both. So John, after people have a chance to look at this great group, when you take the slides down, and Diana, if you could come on as well, that would be fabulous. All right, let me, there we go. Great. So your talk's freshest in my mind, Jonathan, so let me start with a few questions for you. At this point, do you think it's an informed consent discussion with a patient about sleeve versus Roux-en-Y? You convinced me if I was going to get the surgery, I'd want a sleeve. So why is the other one an option?
So at UCSF, about 80% of our patients go for the sleeve. The only patient that you would not offer a sleeve would be someone who is a bad refluxer to start. And so what we ask is, our red flag is we see if someone's PPI dependent. Now, if you look at GERD, about 40% of obese patients who seek bariatric surgery have GERD, have pathological GERD if you look for it. So it's a very prevalent disease. And so, how are you going to decide? And so we just look for daily PPI use. If someone's really dependent on a daily PPI, they probably should not get a sleeve and go for the bypass. The bypass actually is a wonderful cure for GERD because you're essentially detaching the esophagus from the stomach. So the acid from the stomach can't get back up in the esophagus to burn it anymore. So that's the one category.
And how does your decision making about the appropriateness of a patient for surgery change with the new meds? Are you going to want to see that they have, I hate to use the word failed, but you want to see that they've tried the meds, it hasn't worked first? Or is it sort of the same way you thought about it 5 years ago?
Well, I mean, everyone's excited about these new meds, but I mean, it's still premature to get too excited, right? We have 1-year data from the SURMOUNT. There is no 5-year data. There's no 10-year data. We know that if you come off meds that you're going to regain the weight. And these meds are not available. I mean, I'll tell you, Diana and I were chatting. I've been trying to prescribe these meds. My success rate is 5% or less. Insurance doesn't cover it. Patients can't pay for it. With Wegovy, we had a huge manufacturing shortage shortly after it was FDA approved for obesity. So it wasn't available. The manufacturers have priced these astronomically, $1,400 a month. So if you were to say like, oh, well, it's rational to try meds for a year or two, see if you're successful. If you're not, maybe think about surgery. I think that's a reasonable, rational approach to this disease. Practically speaking, if these patients don't have access, we got to solve that problem first and go from there.
And insurance, I assume your surgery is not that cheap either.
Yeah.
Does insurance invariably cover your surgery?
It's hit and miss. What's interesting about bariatric surgery is it is a discrete coverage benefit. And so your employer either opts in or opts out of it. So you might sign up with Blue Cross Blue Shield But if you're a Google employee, like Google corporate may not have bariatric surgery as part of the Blue Shield plan for its employees. And so it's really hit and miss. But I'll tell you the benefit to patients is so compelling. And I shared a little bit of that it's really hard for an insurer to argue against it, right? I mean, if this were your mother or your brother or your child, you have to be scared of the obesity. That obesity is going to take 10 years off their life. Yeah. And you've got to do something that works. And, you know, the bariatric surgery we've shown has powerful metabolic, durable effect out to 20 years. And so you're on a way better risk profile doing the surgery than not doing the surgery.
Yeah, great. And maybe final question for you, and I'll turn to Diana, is you run a bariatric surgery training program, fellowship. Is this a highly specialized procedure, and particularly now that you're switching to the sleeve? Or is, you know, someone goes and is looking around and sees a general surgeon, and this is one of the 10 surgeries they do. Is that okay, or how specialized is it?
It's a little bit middle of the road. It's not tertiary care, super specialized. But within the bariatric world, there is an accreditation program that's run nationally. If you're thinking about referring a patient or have a patient, you want to make sure that you refer them to an accredited program. And what you get with that is a guarantee of minimum surgeon case requirements, minimum surgeon training. Effectively, you have to be fellowship trained in order to get accredited. There's also minimum hospital requirements. And then there's quality benchmarks. So they look at your SSI and your leaks and your DVTs and stuff. And if it's too high, you don't get accredited. So the best thing, I think, for anybody who's thinking about this is to make sure they go into an accredited program. That's how they can be sure that they get a quality team. Great,
thank you. Diana, let's talk a little bit about, that the results are impressive, but so is the rebound effect and the fact that you regain 2/3 of the weight on average. What do you do at the end of a year? Are you telling people that you need to stay on this medicine forever? And I know there's a dose escalation as you get on it. Do you then back down to a lower dose, or do you stay at the highest dose? And kind of what are you thinking about the chronic phase of treatment with these meds?
That's a really interesting and nuanced question. It's totally uncharted territory. So I think in the long run, patients will probably need to be on medications. It might not need to be continuous, but we don't know who's going to need to stay on the high dose, who we can wean down on. And like when someone is like, I'm done, or, I've been doing this for a while, I have really good lifestyle change in place, let's start to wean down, and we'll see where they start to gain weight back. The bigger issue, however, is that most people change insurances very regularly throughout their lives. So I see way more commonly that, hey, I got a new job, or, something in my life changed, and now my insurance company is not going to cover this, and I have to stop in a month. That's realistically what we're seeing. And that's a much, much bigger problem. And then also what Dr. Carter mentioned, there were initial supply chain issues with Wegovy. And again, now there are supply chain issues. So patients who were started on 0.25, they're having total issues with the 0.25, 0.5, and 1 milligram dose. So patients were started, now they can't dose escalate, but they can't even find the maintenance dose. So we've all been put in a pretty horrible position. And then we have people who are then saying, okay, we'll just take Ozempic. And then our patients with diabetes who actually need it for life-saving reasons aren't getting that medication.
Is Ozempic and Wegovy, are they actually different enough that you couldn't take Wegovy for diabetes and you shouldn't take Wegovy for, are they basically the same med and it's just the labeling issue?
Yeah, so for pharmaceutical purposes, they're the same. Wegovy goes up to higher doses to 2.4, whereas Ozempic is only to 2, and sort of dose escalation is slightly different, but it's more ethical issues. If, there was an abundance of supply of Ozempic, I think it would be fine. But when we're seeing normal weight people who are just wealthy buying Ozempic out of pocket and taking it out of the hands from our patients who need it for their diabetes care, it's really a problem and a societal ill.
Yeah, got it. When the oral meds come out, will you think your typical practice will be to switch to them, or are there advantages potentially of a once a week shot?
I think the advantages of the oral medications are it's just easier to travel. It's already pretty consistent with people's lifestyle of taking meds. Some people, however, do better with medications that they don't have to use as regularly. We don't know. We don't know if the oral higher dose Ribelsis will have the same levels of weight loss, or will the side effect profile be acceptable, or will there be something about the oral pills that just have more toxicity? So I think we still have to see what the results show, but if it's similar and patients tolerate it better, I think most patients will prefer the oral option.
Okay. Kelvin Moore asked, is there any more information on this relationship between the agonists and suicide ideation? Do we know what's going on there?
That's a super interesting question. Well, currently GLP-1 receptor agonists are being studied in addiction medicine. So I think as they look at those brain pathways even more in depth, we'll start to learn more about what's going on that's increasing depression or suicidal ideation. But right now it's not really fully fledged.
Mm-hmm. Edgar Pierluisi asked, for each modality, both meds and surgery, what proportion of the weight loss is muscle compared to fat? Do we know that?
For the Wegovy studies, it was about 40% of weight loss was from lean muscle mass. I don't know, John, is that similar for surgery?
It's similar. So a typical bariatric patient will lose, of the weight that they'll typically lose 50% of their fat mass and about 10% of their non-fat mass or fat-free mass if you do a DEXA study. So the short answer is mostly fat, but a little bit of muscle.
Okay. John, we didn't talk about any endoscopic approaches. Are there, when we think about an intervention that's beyond lifestyle and medicines, are there other alternatives beyond surgery to consider?
Funny you should ask. So I'm one of my hats that I wear is I'm chair of the Clinical Issues Committee for the Bariatric Professional Society, ASMBS. And so we just finished a position statement on endoscopic sleeve gastrectomy, which is a endoscopic attempt to recapitulate the sleeve gastrectomy that I showed you. If you look at ESG, weight loss is about, it's between 11 and 14% total body weight loss at 1 year. So it's better than placebo. It's not anywhere near as a laparoscopic sleeve, so it's markedly inferior. It sort of was positioned, its sweet spot was for these people that are in the BMI 30 to 40 range, where you're not a candidate for traditional bariatric surgery. And the problem is, now that we've reduced the BMI cutoffs, that window for endoscopic has now shrunk, and it's hard to, I mean, I'll tell you the results of tirzepatide are better than ESG, than endoscopic sleeve gastrectomy. So I don't know, if I had a BMI of 33, I don't know why I would do an ESG with a non-zero complication rate when I could just get tirzepatide and get better weight loss with that. So I don't know what the role is for these endoscopic things in the future. I think their window is sort of shrinking and it's being pushed. You know, medicines are getting better, and then the indications for bariatric surgery are getting lower. And so the endoscopic is getting squeezed out, I think, in the middle.
Makes sense. Might be the last question. Diana, these meds are so new and they feel somewhat magical with a disease, you know, a whole category that we just had nothing to offer patients, and now we have these a number of choices, and they seem to work really extraordinarily well. Anything you worry about, like 5 years from now, 10 years from now, we're going to find out that they cause X, and we'll sort of regret the fact that we put them out there fairly quickly?
Yeah, I mean, I think anybody who's been in the space of obesity management knows that there is no silver bullet. And we've been burned by meds pretty badly with something like Belviq in the past. The upside to GLP-1 receptor agonists is that they're not new as a medication class. So, you know, Saxenda was FDA approved in 2013 for weight loss, but liraglutide in the form of Victoza and exenatide, an oral GLP-1, was FDA approved way before that. So it's been about 20-ish years since we've had something on the market, which is reassuring. Something like tirzepatide, I personally don't use off-label because it is brand new. And I think it's really important to have it be FDA approved before we start to use it. But that's a really good question. And we see lots of issues come up with medications decades later. So we'll see.
Yeah. I think you have to temper that with the known complications of obesity decades later, and as you're making these complicated decisions. But well, thank you both for terrific talk about one of the more interesting areas in medicine, one of the ones that's most important to our patients, and it's evolving very quickly. Thanks so much. If you folks who want CME credit, please stay on. You'll see the address to do that. Next week, we'll be talking about lung transplantation. We'll also have one of our colleagues in medicine and a colleague in surgery to talk through another area that's rapidly changing. So thanks so much. Good to see you all.